Alongside with me, Dr.
Ketan Mehra. I am Assistant Professor Urology at AIIMS Bhopal.
Over the next 10 to 15 minutes, we are going to discuss about the management of lymph nodes in renal cell carcinoma. So whenever we are going to discuss about the utility of lymph node dissection, we have to see various facets of this procedure, namely its staging utility, its prognostic significance, as well as any therapeutic significance that it may have.
Coming to the staging of the lymph nodes can be done by two methods. First is imaging modality and second is by surgical method. In imaging modalities, as you can see, the computed tomography and MRI, these two can even miss small lymph nodes that are less than 1 centimeter. And another fallacy is if the lymph nodes are more than 1 centimeter, there are 58% chances of having reactive hyperplasia. On the other hand, the functional scan, that is FDG PET scan, can diagnose even the smaller lymph nodes which are positive.
So the other method, which is the gold standard to detect the involvement of a lymph node pathologically, is surgical staging, whereby you do the surgical excision of the lymph node followed by histopathological examination. An important caveat here is that in addition to the conventional H&E stain, it is imperative that you perform a immunohistochemistry of the lymph node so as not to miss any micrometastasis that can be missed.
The lymph nodes dissection can be used for prognostication. It is very helpful in prognosticating the disease, the RCC. This is the primary study by Robson et al., which showed about that lymph node dissection is very much helpful in prognostication, and it shows that if lymph nodes are positive, it has a very poor prognosis in the disease. As we can see that the overall survival in lymph node positive disease, for 1 year it is 68%, for 5 years the overall survival becomes 28%, and the 10-year overall survival is 18%. That shows that prognostic role, the positive lymph nodes has a very dismal prognosis.
Other studies have also shown that even in patients who have a primary disease which is T1 or T2, the presence of pathological nodal disease makes the prognosis even worse than a patient who has locally advanced primary tumor in the form of T3 or T4 in the absence of any nodal disease. And this is reflected in all outcomes, oncological outcomes, be it metastasis-free survival, recurrence-free survival, overall survival, or cancer-specific survival. Also, for a given T stage, the presence of nodal metastasis confers a poor or a dismal prognosis. And this lymph nodal positivity has highest prognostic value for a low stage or low grade disease. For that I mean, suppose a patient has a nodal involvement in T1 stage, the chances of a patient dying due to cancer become 6-fold as compared to a patient who has nodal involvement for T4 disease, where the contribution of dismal prognosis by the nodal involvement is lesser.
Now coming the therapeutic utility, which is the Achilles heel, there are various studies which shows that there are no benefit of lymph node dissection in RCCs. However, there are some studies which shows that there could be some benefit doing lymph node dissection in RCCs. That means there are various studies with different results.
The only prospective randomized trial in this regard is the EORTC 30881. It is a randomized trial where they have randomized the patients into two groups, radical nephrectomy alone versus radical nephrectomy with a lymph node dissection. Of the 346 patients who underwent lymph node dissection with radical nephrectomy, the nodal positivity was only 4%, and the study concluded that there is no oncological benefit of performance of a lymph node dissection. Critical appraisal of the article reveals that 75% of the patients in this study who underwent lymph node dissection had T1 or T2 disease, where itself the involvement of lymph nodes is very less. In addition to this, the template of lymph node dissection was not specified by the authors.
Now, why the lymph node dissection in RCC does not have any therapeutic benefit? So, first of all, the lymphatic drainage of kidney is very different. We cannot predict the lymphatic drainage, and hence we cannot predict the lymphatic dissemination also. There is no any standard template for lymphatic dissection which is being practiced by anybody. And the factors that predict the lymph node metastasis are the same factors which also predict the systemic disease, the metastasis in elsewhere. So there are always, not always, there are associated, there could be associated occult systemic disease in patients which have lymph node positive disease.
Now, discussing these points in detail, we said that the lymphatic drainage of RCC is complex and unpredictable, and it is seen that in almost 46%, so almost in half of the patients, there will be skip metastasis to the para-aortic or the paracaval lymph node without involvement of a hilar lymph node. On the other hand, almost 1/3 of these patients will not drain into the regional lymph nodes and may have direct connections to the thoracic duct. The theory that the nodal disease may be associated with occult systemic disease is on the basis of observation of various studies, where they have seen that after radical nephrectomy and lymph node dissection, patients of node positive disease were followed. Majority of the patients have recurrences, but these recurrences are in most cases multi-organ metastasis, and in only isolated cases are these retroperitoneal recurrences. Similarly, in this study by the Mayo Clinic, they saw that out of the 138 patients with isolated nodal involvement at the time of radical nephrectomy, 108 patients recurred, with majority of them recurring in systematically. So they concluded that in patients in whom clinical as well as pathological examination at diagnosis reveals isolated nodal disease in the absence of overt metastasis, there is some component of occult systemic disease that always persists. In addition, we have noted that multiple studies have varying lymph node dissection templates, which makes the interpretation of all the data very difficult.
As told by Dr. Ashish, there could be therapeutic benefit also in lymph node dissection. So there are two observations which shows that there was some therapeutic benefit in lymph node dissection. However, it was associated that in patients in whom we have benefit, those patients should have extensive lymph node dissection along with at least less than two or less than 2 lymph nodes positive, as compared to the patients in which there was limited lymph node dissection. So in nearly all patients who were free of progression for 5 years, there was disease free further also. So this is also one of the factor.
So what Dr. Ketan is trying to point is that there is a small subset of patients of renal cell carcinoma with limited nodal positivity who may benefit and continue to have durable responses even after lymph node dissection. However, at present, our ability to identify such patients is limited. So now we have discussed that the lymph node dissection has a staging and prognostic capability. In patients who have nodal disease, you may opt to do surveillance more aggressively, and they may help you select these patients for adjuvant therapy, especially in the form of pembrolizumab. But now the question arises in whom you should offer lymph node dissection, and the question is answered by the guidelines presently that it should be offered in patients who have clinically enlarged lymph nodes, as well as in those patients in which the primary tumor characteristics makes the patient a high risk candidate for lymph node involvement.
Now in whom we should go for lymph node dissection. So this is the criteria by Blue et al., in which they have mentioned some features like nuclear grade, sarcoidoid component, tumor that is more than 10 centimeter, primary tumor stage that is PT3 and PT4, and histological tumor necrosis. So if any of the factors, if 2 factors are positive, lymph node dissection can be contemplated in the patient.
Crispin et al. Used the same criteria and identified 169 patients of high-risk renal cell carcinoma. The percentage of lymph node involvement was 38%, and interestingly, these factors of the primary tumor are identified by intraoperative frozen section. Another important aspect of this paper was they had done bilateral retroperitoneal lymph node dissection and identified the recommendations for surgical template. They found that in these 64 patients with lymph nodal involvement, 45% of these patients do not have hilar lymph node involvement, and therefore if you just resect the hilar lymph nodes, it is a limited value dissection. They also found that for right-sided cancers, there is no isolated para-aortic lymph node involvement, and similarly for left side, there is no isolated paracaval involvement. What they are trying to say is that the template of dissection should be an ipsilateral extended lymph node template, extending along the ipsilateral vessel and also including the interaortocaval groove.
Now, how many lymph nodes should be considered the optimum? So there is one study, you can see that by Taron and et al. It shows that if the lymph node numbers that we are dissecting are more than 13, then the positivity rate also goes up, that is 20%. And if the lymph nodes number are less than 13, the positivity rate becomes almost half, that is almost 10%.
So what we are trying to convey is that extended lymph node dissection is the template to follow, and a minimum lymph node yield of 13 is expected to be indicative of a good dissection. So finally, coming on to the take-home messages for our talk, lymph node dissection has definitive staging and prognostic benefit. The therapeutic benefit for lymph node dissection is still controversial, although there may be a subset of patients with limited nodal disease who may continue to experience durable responses. High-risk factors as elucidated by Blut et al. Can be considered for performing lymph node dissection, and extended unilateral template is the way to go if one chooses to perform the lymph node dissection. Thank you.
Thank you.
Well, thank you, Dr. Ashish and Ketan. You have done nice dissection of the literature. What ultimately where we have reached, if I remember of my residency day, I still remember in Campbell edition 3, what you mentioned in the first line, the same thing was written, that lymph node dissection will certainly stage the disease and you can prognosticate, nothing beyond that. And I believe we are still there at the same stage after 40 years.
Yeah, true, sir.
So, as you mentioned, the lymph node drainage of the kidney is very capricious, is very not defined. That may be another reason that we don't know the true template, what should be the template. Then you mentioned directly going to the thoracic duct, some of the lymphatic bypassing, all those areas. So, there are certain things still we need to know, I think. But as of today, where we stand, very nice that you have done the literature review and presented. Thank you.
Thank you, sir. Thank you, sir.
Just one more question. There is an inherent contradiction when you on one hand say that when there is a lymph node metastasis present on imaging, there is a very high likelihood that there is a systemic metastasis present. And on the other hand, you suggest that doing lymphadenectomy in these cases can have a therapeutic benefit. So I would like you to elaborate a little bit more on that.
So that study where we said that patients with limited nodal positivity on an extended template, that means if you have dissected the retroperitoneum, you have got 13, 18 lymph nodes, and then you get up to 1 or 2 lymph nodes, these patients are actually having limited nodal disease, and such patients may have durable response. On the other hand, in the same study, if a limited template was done and about 4 lymph nodes were taken out and 2 were positive, and you treat them in the same way, they perform worse as compared to these patients.
No, so this is based on the frozen section of the...
no, sir. This is final histopathological examination. What I mean to say is that adequately done lymph node dissection, if it reveals a limited disease...
No, so does that mean you should be doing template extended lymph node dissection in everybody?
Yes, sir. That is what we have suggested.
That is the particular study,
that
sir.
In patients who have high risk criteria for lymph node involvement, the way to go if we are choosing to do a lymph node is an extended.
Should it be done in clinically node positive patients or clinically node negative patients who've got high risk features on the primary?
So for clinically node,
that's where if you do a good dissection, you may be able to clear off the micrometastatic disease, and that may have some therapeutic. I mean, there's no RCT on it.
Yes, yes.
You know, and there never will be, because we are all doing minimally invasive surgery. Nobody has the time to do RP-LENDs and all that.
I think that's the you have given the message. Whether you do limited or extended, you are at the same point where you have started, and you may have to look up to immunotherapy or immune checkpoint inhibitor. That may be the option next, whatever is your limit of the dissection. Thank you very much.
So Ashish, even I got confused. Let's say there's a right-sided tumor which has got all high-risk features, but clinically there are no nodes. Now you know that the template for a right-sided tumor is also the interaortocaval groove. So that patient comes to me. I take out his right-sided tumor. I remove the gerota, everything, lay bare the IVC. Do you want me to go into the interaortocaval groove and do a lymph node dissection?
So the guidelines and the literature suggest that just doing a hilar dissection, doing a radical nephrectomy with hilar lymph node dissection is of no use. If you are choosing to search for lymph node involvement, for that you need to do a good template dissection, and according to the guidelines at the moment, by mapping studies, it is advisable that you do the paracaval, retrocaval, interaortocaval lymph node dissection.
But don't forget that you are increasing the morbidity.
Should be done under a study protocol,
yeah.
not in
not
clinical
generally.
practice.
Otherwise,
Yes,
you're just
that
doing,
is what
yeah.
I wanted.
Yeah.
Because by doing this type of extended lymph node dissection, certainly the morbidity will increase.
Yes.
You should keep in mind. You are not adding anything to the patient benefit, but you are giving him downside.
So again, this statement is a little controversial. The EORTC trial 30881 categorically says that there was no difference in the complication rates, although there are studies, definitely the incidence of chylous ascites, vascular injuries, lumbar vessel bleeding, obviously these will occur, but in expert hands, I think the complications may be balanced.
Thank you.
What was the year of this study?
Sorry, sir?
Which year this study was
The
done?
study started in 1989 and then they had completed 30 years. So if I'm not wrong,
At that time there was no CT scan, MRI scans, PET scans, nothing. Only.
there was CT scans,
No,
sir.
I mean, not that Ross. This is a 30-year-old study.
Yes, sir. But CT was definitely there, sir. That time.
Thank you very much. Now coming to the last lecture on this session, I would like to invite Dr. Avani Tiwari and Dr. Shruti Sabnis for the talk on importance of pathology in management of small renal masses.
Good evening, everyone. I'm Dr. Avani Tiwari from Regional Cancer Center, Raipur. And with me is
I'm Dr. Shruti Sabnis from MPOH Nadiyad.
So we'll be talking about the importance of pathology in management of small renal masses. There is an increasing incidence of renal cell carcinoma in last few decades. And small renal masses are defined as solid or cystic enhancing kidney tumors or lesions which are less than or equal to 4 centimeters in size and which corresponds to the PT1A of TNM staging. They are usually incidentally detected and this is attributed mainly to the liberal use of abdominal ultrasound or abdominal sonography these days. And as we all know, not all small renal masses are malignant, but those which are, they have heterogeneous features and significant proportion of them are considered to be of low malignant potential. Although there is increase in incidence of small renal masses, mortality has not increased proportionately. And this can be attributed to the fact that 20 to 30% of these lesions are benign and they have an indolent course. So now there is an increasing concern about the morbidities of the treatment of potentially indolent lesions. Understanding the biological behavior through histomorphology shows improved prediction of the local tumor growth or stage progression and their metastatic potential. Whenever there is ambiguous clinico-radiological correlation and now there is an absence of special biomarkers for it, the best method to characterize small renal masses is a renal tumor biopsy. Now the role of pathologist is at pre-operative, intraoperative or at the post-operative levels. So now the indications for pre-treatment renal tumor biopsies. So all small renal masses should be considered for biopsies when the results may alter the management of the tumor, and it should be considered when the mass is suggestive of any lymphoma or any inflammatory lesion. It should also be performed before the thermoablation for the diagnosis and after ablation to guide the surveillance. It is contraindicated predominantly in the cystic masses and the renal masses which are originating near the collecting system. Also in frail or older patients where the management will not be changed after the biopsy, it shouldn't be performed. Now coming to how biopsy helps in management. Now as soon as we see the biopsy, we have to consider whether the lesion is neoplastic or non-neoplastic. First should be the difference between, to find out whether it's a neoplastic lesion or not. So we have a differential diagnosis of abscess or localized xanthogranulomatous pyelonephritis or tuberculosis. All these presents as small renal mass, but diagnosing these will completely alter the management. Now if the lesion is neoplastic, we have to find out whether it is a benign or a malignant lesion, because benign lesions again like fat poor angiomyolipomas or oncocytomas or metanephric tumors, diagnosing these will also alter the management of the patient. If malignant, we have to see whether they are renal cell carcinomas or not. Because if they are not renal cell carcinomas, they can be hematolymphoid malignancies, which also present as small renal masses or metastasis from other tumors. So in these cases, the treatment depends upon the primary lesion. Now, if the tumor is RCC, what we see, we look at the biopsy and we identify what is the morphological subtype of the tumor. So basically there are three main morphological subtypes. One is clear cell subtype, another is a papillary subtype, and third is a chromophobe subtype. But it is not always easy to differentiate all these three entities as separate ones. We have a clear cell variant of clear cell RCC, which is a very aggressive tumor. But there are tumors which have overlapping features and they are showing clear cell morphology, and many of them are having a very good prognosis. Then we have a non-clear cell papillary pattern or papillary RCCs. Again, this is also a part of a mixed morphology tumors, and we have a list of tumors which are presenting as a papillary pattern, but they have a better prognosis. Again, the third pattern is a chromophobe type, which is also again intermediate prognosis tumors, and these are the list of tumors which are having intermediate prognosis, plus they have a chromophobe type of morphology. So now we know that there are various morphological features which are overlapping, and it is very difficult to diagnose it on a small renal biopsy. If there are intermixed features of clear cell or papillary or chromophobe type, then they points towards the newer molecular defined RCCs. The second part is the histological tumor characteristic itself, which need to be considered in decision making. The first is eye subgrading. As we all know that eye subgrading 3 or 4 points towards an unfavorable prognosis, and eye sub 1 and 2 are a better prognostic features. Sarcomatoid and rhabdoid features separately, they are of a poor prognostic marker, and necrosis and lymphovascular invasion should also be mentioned in the biopsies because they also point towards a worse prognosis. Now, coming to role of IHC on preoperative biopsies. So, if the diagnosis is clear, if there is a clear cell morphology, it is not recommended to use IHCs. But if the morphology is ambiguous and we are confused, we are not sure whether it's which type of RCCs, we have to use a basic panel. So, basic panel is CA9, CK7 and CD117. And Dr. Sambit also mentioned just now that we have to include BAP1 also, because BAP1 loss is associated with a very aggressive morphology. So first is a PAX8, which is a lineage biomarker, which is a lineage IHC marker for renal tumors. If it is positive, then we use CA9 and CK7. If the tumor is CA9 positive and CK7 negative, it's a clear cell carcinoma. If it is CA9 and CK7 both positive, it's a clear cell papillary RCC. And if it is CK7 positive and CA9 negative, again we have to look for the morphology. And if we are not clear whether it's going towards a papillary one or a chromophobe one, we have to use CD117. So CD117 is negative in papillary RCC and CD117 is positive in chromophobe RCC. So this is how we use a primary algorithmic IHC markers for the diagnosis. Now, there are certain cases where IHC markers are not helping and the morphology is suggesting about some newer morphologies or genetically defined RCCs. So, we have a list of these advanced IHC panel markers which are used whenever there is a morphological suspicion of certain type of morphology. There is one more important point to note here is that according to WHO 2022, the diagnosis of oncocytoma, clear cell papillary renal cell tumor and multilocular cystic neoplasm of low malignant potential should never be made on a small biopsy because there is a limited sampling and there is a overlap between their malignant counterparts. Now Dr. Shruti will take you forward.
So after pre-tumor biopsies, we come to the intra-operative assessment where the question comes for margin positivity. So margin positive is something where the tumor is touching the inked margin either macroscopically or microscopically. It has been a long-standing debate for the significance of frozen section to be performed during the margin assessment. The significance still remains controversial after many studies. because there is a high false negativity rate with frozen section assessment. What we do instead of the frozen section in our institute is we do intraoperative gross assessment. We go to the OT as the sample is retrieved. We bisect it, look for a proper resection, and only in the cases where it is seems doubtful, only there we go for frozen section or confirmation by frozen section for clear margin. The other thing which is noted that is positive margin does not always correlate with recurrence. So there were studies where they found that positive margin did not show any local recurrence, but local recurrence was seen in specimens which did show negative margins in the permanent section as well. So again, the significance of margin assessment in the end still remains controversial. So this is the new, once the final histopathology is done, this is the new WHO 2022 classification, where this one section of molecularly defined RCCs has been introduced, and the dilemma of this section is for the prognosis of this. So if we look at these tables, not all molecularly defined RCCs are aggressive. Some of them have actually a very indolent course, but some of them have actually a very aggressive course, even worse than the clear cell RCCs. Usually in small renal masses, we do not see these aggressive types of tumors because they grow very fast, and till they are diagnosed, they are already advanced. So most of the time, small renal masses present with these indolent kind of molecularly defined RCCs. In final histopathology, other features which are of poor prognosis is stage T3A. First thing, small renal masses can sometimes show microscopic invasion of perinephric fat or renal sinus on final histopathology, which upstages the tumor and significantly worsens the prognosis. Aggressive histological subtype, presence of sarcomatoid rhabdoid features, higher ISUP nuclear grade, and presence of tumor necrosis or lymphovascular invasion again worsens the prognosis. The other thing important to consider is some subtypes of RCCs are associated with genetic predisposition syndromes. So in the new WHO 2022 Blue Book, they have given a separate section for genetic predisposition syndromes, and among those associated with RCCs are the VHL, BHT, hereditary papillary carcinomas, the HLRCC, which show FH deficient tumors, the SDH deficient tumors, the BAP1 predisposition, and tuberous sclerosis. So presence of any of the RCCs associated with these tumor predisposition syndromes, presence of a family history in first degree relative, or an age of less than 46 years, or a bilateral or multifocal tumors. These are the conditions where the patient has to be sent for genetic counseling for presence of any of these predisposition syndromes. Dr. Avani did talk about IHCs. If we come to the molecular tests which are important for small renal masses, FISH is very important because some of the molecularly defined RCCs, especially TFE3 and TFEB, the IHC is not very reliable. There is a very high false negativity rate. And FISH is very confirmatory, not very expensive, and good test for the diagnosis of these subtypes. The other important one is in case of RCC NOS. We can go for some limited RCC panels by NGS, where some mutations, if they are present, they can help subtype these tumors to reduce the diagnosis of RCC NOS and better prognostication. So if I summarize in the end, renal mass biopsy has its importance in limited settings where it can actually influence decision making. Diagnosis of benign tumors or indolent tumors should be done with caution on a renal biopsy, especially of what Dr. Avani mentioned, oncocytomas, the clear cell papillary tumors, and multilocular cystic RCCs. Frozen section assessment has a very no clear consensus, very doubtful role. Final histopathology still remains the mainstay. And for syndromic association, a good clinical assessment and history taking and genetic testing has to be done. Thank you.
Well, thank you, Dr. Tiwari and Dr. Sabnis, really giving us an update on the recent WHO classification of 2022, and in which we know as a urologist, earlier we used to classify the papillary into 1 and 2. Now that classification is gone. Now it is only renal cell papillary carcinoma. And regarding the prognosis, as you mentioned, the prognostically it is the multilocular cystic neoplasm of low malignant potential is the best one.
Yes.
Then is the chromophobe or the papillary.
Yes.
Then is the RCC, in that order.
Yes.
Thank you very much. I thought I got the gist of your lecture.
Just have one question. What is the basic minimum panel of IHCs that you should have to diagnose most of these RCCs? Do you take the age of the patient, like you said, no? Family history, age of the patient. When do you decide what all panel of IHCs to be
So much more than age and everything, first is the morphology. What does the slide show? What does the HNE show? If it is a clear cell RCC in a specimen, it is usually does not require any kind of IHC for diagnosis. But
is that for sure that if you see clear cells, you are 100% sure that's clear cell RCC?
When you are 100% sure, you don't need any support of markers. But if you are doubtful in cases, you can use the markers which he mentioned, CA9, CK7, CD117. So these three are the basic ones which will actually help you diagnose the most common RCCs, the clear cell, the papillary and the chromophobe. So these three markers will cover almost 80% of your RCCs. And then comes your type 2 papillary patterns, which were previously a class, now they have been removed. So these will need a very large and extended panel for the last 10 to 15% of tumors, which is a very long list and every institute might not have. But at least 3-4 markers, PAX8, CA9, CK7, CD117 will help you diagnose about 80 to 85% of all RCCs.
Yeah, what she said, like, I agree with her. I mean, in the clear cell, particularly when you have a small biopsy, you definitely need IHC. Even if it is absolutely clear cell histology, in a small core biopsy, you need a keratin 7 and a CA9 and a PAX8. I mean, CD117, I would probably not recommend on a clear cell because we do not want to waste money on that. Probably we'll go for
ultimately the patient has to pay the money.
Yeah, exactly.
It's a financial burden on the patient.
Some stains, if your pathologist is doing a CD10, tell them not to do it because CD10 absolutely has no value. I was involved in the kidney chapters in WHO.
Well, so pathologists are not under control. They do what they think should be done, so they will do it.
BAP1 is one thing I just want to add because in Delhi we are doing BAP1 in Rajiv Gandhi in our center also. Some RCCs, they look absolutely clear cell, but with no morphology, but they have a BAP1 inactivation and they behave very, very aggressively. So putting a BAP1 IHC which is available in India is a good.
Thank you.
Sir,
thank you very much.
Sir, I have one last question. One of the RCCs, a partial lab partial nephrectomy was done, and it was looking like preoperatively a clear enhancing mass, looked like a clear cell type. But if on the final histopathology, angiomyolipoma fat poor with epithelial cyst, MLEC was the one differential, and with mixed epithelial and stromal, MEST. And what should be our follow-up of this patient? Should we go for IHC and how can I proceed to confirm the diagnosis?
AML, the question for here is AML is actually not absolutely benign.
Yes, yes.
Yeah,
that's I know.
Epithelioid AMLs are malignant disease.
But the pathologist was not sure whether it could still turn out to be an RCC.
Yeah, IHC is definitely required to.
That's my point. And MEST was another differential. Yeah. Mixed epithelial and stromal tumor.
So IHC in that
case, IHC is recommended in this case or not?
Yes. IHC is absolutely yes. We needed to differentiate MEST from AMLs.
Okay. Sir.
MEST will have a better prognosis than epithelioid AML.
MEST is sort of benign.
Yeah, so epithelioid AML will show local recurrence and distant mets and lymph node involvement, everything.
If the margins have been negative in this case, so there is not much chances of recurrence.
Thank you. I think we can discuss on a session.
Yeah,
now we have to call up. Thank you very much.
It is too interesting a discussion, Sambit. Thank you very much. Yeah.
Yes.
Now this star